Welcome, everyone. So good to see you streaming all in from the waiting room. Hello, hello. We have a big crowd planned, so it could take us a little while for everyone to get settled and get connected to audio and video. So I'll take this time to go over some housekeeping items. Let's see. We do have either closed captions or a transcript available. We've turned on that option. So if you prefer to read as well as hear the presentation, you can toggle that on and off. You can control that in the bottom menu bar. The More menu, it's the three-dot ellipsis. If you click on that, you can choose Show Subtitles, or turn off subtitles, view transcript, or turn that off. We will also, we're recording this, so you'll be able to watch it back. And our guest, Carley Rusch, has offered to share the slides that she's going to be presenting. So soak in all the information, and don't worry, there will be a way for you to access the slides or the recording afterwards as well. Your connection to the discussion is going to be via the chat feature. So again, that's in the middle of that Zoom menu bar, the little speech bubble in the middle of the bottom screen. And I invite you to give it a try and pop something in the chat. And how about, since we're talking about food, it's lunchtime, and we have a clinical dietitian as our guest. Why don't we pop in the chat what you had for your last meal? And I'll add mine. I had 2 cups of coffee with cream and sugar, and then I was like, oh boy, I'm about to talk to a nutritionist. I better have something healthy. So I had a banana. I squeezed in a little something. I don't even know if bananas are healthy, but that's what we all tuned in to learn about. So I think that covers all my housekeeping items. So let's get started. Welcome, everyone. My name is Andrea Miriam. I'm your host with the Parkinson and Movement Disorder Alliance, and we're so happy that you tuned in to join us in this little virtual pocket of the internet to learn about diet, gut, nutrition, and how it impacts Parkinson's. I do want to set the stage and make sure that we are being fair to our presenter. And if you tuned in to hear about that one magical food that will make all of your symptoms go away and, make your Parkinson's do a 180, as far as I know, that doesn't exist. However, we all eat throughout the day, and it's a choice that we do have within our control. So I'm so excited to learn from Carley Rusch about the choices that we make when it comes to our diet, how that can impact our Parkinson's symptoms, and the research, because Carley has some pretty impressive research credentials, what the research tells us as well. So with that, I'll turn it over to you, Carley. Thank you so much for joining us.
Yes, thank you for having me. Thanks for everyone for joining today too. I'm really enjoying reading everyone's breakfast and lunches in the chat right now. I just want to give a big shout out to Daniel, who was unafraid to put that he had fried chicken. Everyone else has been putting like oatmeal, bananas, eggs, fruit, and Daniel, I appreciate you, man, for being honest, putting out there that you had some fried chicken today. Thank you. Because, as a dietitian, one of the things people always ask me is, well, don't you eat healthy all the time? You must never have any junk food. And kind of how I like to look at it is I have a better appreciation for all foods, not just the healthy foods too. So even you can get some nutritional value out of a fried chicken. Maybe not a lot, but so perfect. Well, I will go ahead and get started here. All right, so thank you again, everyone, for being here. Like Andrea said, my name is Carley Rusch. I am a dietitian by training. I am from Florida. I did all my undergraduate master's education at the University of Florida, worked as a clinical dietitian for a couple of years, and then got a phone call to come back to UF to start a PhD in nutrition, primarily focused on nutrition for Parkinson's disease. So right now I'm a doctoral candidate in the Food Science Human Nutrition Department at the University of Florida, as well as I work part-time as a neurology dietitian for the UF Health Norman Fixel Institute for Neurological Diseases. And then for anyone out there who's on Twitter, I'm trying to grow my Twitter following and trying to post more helpful information on nutrition, research, and Parkinson's and other neurological diseases too. So feel free to follow me if you're on Twitter too. All right. So before diving into a lot of the information that I want to talk with you about today, I want to go over, well, what is a neurology dietitian, right? Some people might have heard of a dietitian. Some people might have heard of a nutritionist. But what is a neurology dietitian? Well, first off, the definition of a dietitian compared to a nutritionist is that a dietitian has completed so much coursework and supervised training hours to become a dietitian, where a nutritionist or a health coach, there's no formal requirements to obtain that title. So anyone could call themselves a nutritionist or a health coach. But for a neurology dietitian specifically, there's not really a formal definition for that one either. It's kind of a term that I coined with Dr. Oken here at the Fixel Institute. But essentially what a neurology dietitian is a registered dietitian that works directly with individuals who are at risk for or diagnosed with a neurological disease or condition. And this can be in a variety of settings, whether it's hospitals, rehab, outpatient clinics. I happen to practice in an outpatient clinic here at UF Health. But these are the number of different aspects of nutrition that a neurology dietitian can work in. So we work with people who experience poor appetite, vitamin mineral deficiencies, unintentional weight loss, food-drug interactions, diet education, like we're doing here today, tube feeding management, therapeutic diets, obesity, nutrition counseling, and even people who experience difficulty chewing and swallowing, such as dysphagia too. And just to tell you a little bit about the Fixel Institute, just to brag on them a little bit, because I think where I work is really cool. We primarily see neurological diseases and conditions. We have this brand new building here that we built in 2019, and it's a fabulous place to work and for patients to come and be at. We see not only Parkinson's disease, but a variety of other movement disorders, memory disorders like Alzheimer's, dementia, and other neuromuscular disorders like ALS, MS, and then also TBI too. So, and what's really cool about special about this place is that when patients come to see us, that we revolve around the patient. We have the phrase that the person or the patient is the sun, and we revolve around them. So when you come here, you not only will see your neurologist, but you'll also get the chance to see rehab services, so such as physical therapy, occupational therapy, speech therapy. We have neuropsychology, we have psychiatrists, and you even have social worker and nutritionist too, dietitian. Perfect. All right. So let's dive in. So I know we're all here today because we really want to focus more on what digestive issues are occurring in Parkinson's and how can we use certain aspects of nutrition to treat and maybe even prevent some of these symptoms from occurring too. But I just want to start with a brief overview of all along the GI tract, what different symptoms can occur in someone with Parkinson's. Doesn't mean that everyone will experience all of these symptoms, but from the top down, this is what someone like myself might see in practice. So starting from the mouth, different people, actually many people, can have reduced saliva production, increased drooling, tooth damage from if they have excessive tremor or dystonia, and even slow chewing too. And moving to the esophagus, someone might experience dysphagia, so that difficulty chewing or swallowing. Reduced peristalsis, so what that means is slow motility. So when you chew a food and that needs to go to your mouth, to your esophagus, to your stomach, your intestines, peristalsis is what is that natural movement that helps push food along the GI tract. And so when we think about Parkinson's disease, one of the primary issues that people have is reduced amount of dopamine being produced. We know that dopamine is that neurotransmitter responsible for movement. And when we think about movement, we often think about motor symptoms. So that tremor, that slow gait or slow walking, freezing, rigidity, dystonia, etc., right? But dopamine also functions in the GI tract or the peripheral nervous system and affects motility. So in someone with Parkinson's, they might have reduced motility or reduced peristalsis because of that lack of dopamine and other neurotransmitters circulating. So in addition, someone might also experience spasms or even reflux type symptoms too. Once we get into the stomach, we might also see symptoms of early satiety, so feeling full really quickly, gastroparesis, which just means delayed stomach emptying, and even nausea too as a result of these symptoms. And then once we get to the small intestine, some symptoms that might occur might be just slow transit, so food moving slowly along the intestinal tract. And that might cause abdominal distension, bloating, and even bacterial overgrowth too. And we'll talk a little bit more about some of these things later. In the large intestine, because we have that slow transit time in a lot of people, that's where we might see some symptoms of constipation, so reduced ability to empty your bowels, as well as that bloating, gas feeling, and even in some more severe cases, anorectal dysfunction too. So just an inability to evacuate the stool out of the bowel. But I'm not going to talk about all of these things today because that would just take up way too much of our time, and I want to focus really into the Q&A as well. But at first, we'll start off with the stomach. So let's talk about gastroparesis in Parkinson's. So like I mentioned, gastroparesis means delayed stomach emptying. And typically how this is diagnosed is in what's called a gastric emptying study. And it's typically administered by a gastroenterologist. Usually people will drink a drink filled with a barium solution, and they'll do an X-ray scan and measure how quickly the stomach emptied its contents. If someone experiences gastroparesis, they might have symptoms of nausea, early satiety, bloating, even weight loss or delayed drug delivery too. Because remember, when we take certain medications for Parkinson's, for example, Sinemet or carbidopa-levodopa, we need it first when we swallow it to make its way to our stomach and then empty out of the stomach to be absorbed into the intestine here, right here too. So if our stomach isn't emptying as quickly as it should, that's why you'll often sometimes see reduced effectiveness of medications like Sinemet, because that medication isn't being delivered as quickly as it should. And just to kind of quantify in terms of time what this looks like with gastroparesis. So with a normal stomach, usually takes about 2 hours for our stomachs to empty about 50% of our meals and up to 4 hours to empty the majority of the contents from a meal. Now, in someone with Parkinson's, it can actually take twice as long to empty the stomach in certain cases. So in most people that it would take 2 hours to empty out half of the stomach contents. In someone with Parkinson's, it could take up to 4 hours just to evacuate half into the small intestine. Now, these factors differ based on, the foods that you ate at your meal, whether it was solid or liquid, but this is just kind of a good general overview just to get your thinking about it. And so how we manage it. Typically, when it comes to medication management for gastroparesis, it's a little bit more difficult because of the certain drugs' mechanisms of action. And that's because most drugs and medications to treat gastroparesis are considered what is called a prokinetic agent. So they increase motility. And so sometimes those types of drugs might actually interfere and make our Parkinson's symptoms worse. So it's a little bit on the trickier side to manage with medications. But one of the great ways that we have is diet recommendations. So if you or you know someone that's struggling with this, one of the main key takeaways is to split up the meals. So I know most people generally eat probably 3 meals a day, with the smallest meal in the morning and the largest meal in the evening. But if you really struggle with delayed gastric emptying or gastroparesis, it actually might be more beneficial to reduce your meal sizes and eat smaller, more frequent meals throughout the day. So 4 to 6 meals per day. It's also better to consume lower fat foods and really avoid like fried or processed foods too. We know that fats in particular are that specific macronutrient that really can significantly delay stomach emptying. So if you eat a really big fatty meal and you have gastroparesis, you're going to pay for it a little later. And then one of the more misunderstood concepts of diet management for gastroparesis is whether or not to consume fibers from and we'll talk more about fibers in a little bit, but you just want to caution with certain fibers with gastroparesis, not all, because not all fibers actually delay gastric emptying, only certain ones do. For example, oats and psyllium. Psyllium, if you're not familiar with that type of fiber, is commonly found in a fiber supplement like Metamucil. So these specific fibers in particular have been shown to delay stomach emptying. And that's why they're really effective for appetite control, blood glucose control, because if we delay the amount of food emptying from the stomach, then maybe someone feels has more satiety and they don't eat as much. But if you're someone with gastroparesis, these are definitely certain types of fibers that you want to avoid because you already have delayed stomach emptying and early satiety. So no Metamucil if this is something that you experience. All right, let's move on to the small intestine. So one of the common symptoms of Parkinson's and the small intestine is some people might experience what's called small intestinal bacterial overgrowth, or Sibo, is what another acronym that you might hear for it. And it's been studied more over the past, I would say, 5 to 10 years. And more recently, a recent study in 2021 actually found that it can be prevalent in roughly around 45% of people with Parkinson's. And how you diagnose Sibo is actually by using a hydrogen breath test. Because what they're testing is how much hydrogen is being produced from the bacteria that's present in the small intestine. And so symptoms of Sibo could look like bloating, excessive bloating, gas, abdominal distension, and in more severe cases that I've seen, malabsorption. So when we think about nutrition, the majority of our nutrients are absorbed in the small intestine. And if we have this bacterial overgrowth and bacteria are now taking the nutrients from our diet and using that for energy, we can actually get malabsorption of certain fats, vitamins, and minerals too. And that malabsorption could lead to weight loss and even malnutrition too in some cases. So strategies to manage Sibo. Medications are pretty great, right? So it's a bacterial overgrowth, right? And so in any bacterial overgrowth scenario, whether it's in your blood or if you have diarrhea, etc., antibiotics can be a great method for reducing those bad bacteria that are overgrowing in the small intestine. Rifaximin is a common one used in these cases. However, there are certain diet recommendations that you can follow to help with managing Sibo symptoms. Specifically, really limiting the amount of air that you're ingesting while chewing. So for example, right now, as I'm talking a lot, I'm probably ingesting a lot of air as I speak right now. And if I were to, pick up a piece of toast, for example, I would be ingesting a lot of air. So really chewing with your mouth closed. Carbonation, so sodas, seltzer waters, those bubbles actually also introduce a lot more air into our diet, as well as certain gums too. And the reason why we want to limit the amount of air that we're ingesting is that we already have a buildup of gas and bloating and abdominal distension. So that excess air we ingest through some of these things could really contribute to that. So limiting that. And then in terms of specific foods, because, like I mentioned, these bacteria are utilizing foods and nutrients from our diet to continue to grow and overgrow. Limiting certain fermentable carbohydrates and sugar alcohols that are highly fermentable by these bacteria can be really beneficial for managing these symptoms. So some of the, and I'm not going to go into too much details because I have more information on some other stuff I want to focus on. But if this is something that you're interested in learning more about, the low FODMAP diet is a classic one for managing SIBO. Monash University has some really great information and resources there, as well as the specific carbohydrate diet too, which is pretty similar to a low FODMAP diet. I will say, and I will caution, when it comes to following a low FODMAP diet or a specific carbohydrate diet, I really highly encourage you to work with your doctor or a registered dietitian, because these types of diets function as an elimination diet, meaning we're removing a lot of foods from the diet. And the point of it is to remove the foods and slowly add them back in. And so when I see people in practice who are trying to do some follow a low FODMAP diet, one of the common mistakes that I see people doing is that they remove all the foods, but then they lose a bunch of weight. They become at risk for malnutrition because they haven't started the process or know how to add those foods slowly back in and monitor those symptoms and how it makes them feel. So definitely really work with a doctor or a dietitian if you're considering following any of these diets. Now, probiotics. I promise I'll talk about probiotics a little bit later more. But when it comes to managing SIBO, probiotics have been a little bit more controversial whether to use or not to use. Because remember, in SIBO, we have bacterial overgrowth. So we probably don't want to introduce even more bacteria, even if it's supposed to be beneficial too, just because we don't know if that might make our symptoms worse. So probably should hold off on this. Talk to your gastroenterologist if that's something that you're considering. All right. And now for the majority of my presentation. So we're going to focus mostly on the large intestine. Specifically, I want to touch first on constipation. So we know constipation is a big problem with Parkinson's. It's the focus of my research. And it's one of those issues that, from an outsider's perspective looking in, might seem very well managed. But in talking with people with Parkinson's and just working with people day to day, there hasn't really been a perfect solution developed, and people need a variety of different treatments and therapies to treat their variety of constipation symptoms. But just to give you kind of a general run through, medications, you have some over-the-counter options versus prescription. We're all familiar with Metamucil that I introduced earlier. Like I said, if you're experiencing gastroparesis, probably don't want to choose this one. We also have stool softeners like Dopalax. Osmotic laxatives can work really great in most cases, like Miralax. However, I will say that, and if any of you have used Miralax in the past, you'll know that sometimes too much Miralax might give you the opposite problem at home than constipation. In more severe cases, some people might use suppositories or a fleet enema, especially if it's been like a week that you've had a bowel movement. And then as well as prescription medication like Linzess too could be prescribed by your gastroenterologist. But in terms of diet recommendations for constipation, The best we got so far, especially with Parkinson's, is increase your dietary fiber intake, roughly about 25 to 30 grams per day, and increase your fluid intake too. And I'll talk more about this a little bit later with the research that I'm doing, but the rest of the presentation, I really want to focus more on talking about the microbiome, because we know that from multiple studies have shown that constipation is associated with changes in the microbiome. All right, so what is it? What is the microbiome? Well, I always, whenever I'm giving these types of presentations, it's really, a lot of these terms, especially if you don't have a background in it, can be really confusing and unfamiliar. So I always try to structure these presentations with a lot of definitions for you, so that way you can have that in your toolbox. So the microbiome is the totality of microorganisms and their collective genetic material. So not just bacteria. It also could be dead DNA cells hanging out, but that are present along the intestinal tract. When we refer to gut microbiota, that's referring to the specific organisms of the intestinal tract. So it could not just be bacteria, but also viruses, fungi, and even protists too. And we have a microbiome essentially everywhere, honestly, in the body. I've kind of, with this figure, I've just only focused it on this, the gastrointestinal tract. But now we hear about the lung microbiome, the eye microbiome I've been hearing about. But to keep it simple, we're going to focus on the GI tract here today. We know that when it comes to the microbiome, it thrives best in less acidic conditions. So if you think about the stomach and the small intestinal environment, a very acidic environment. So you're not going to see very many bacteria in particular hang out here. But once we move along the stomach, the small intestine, get down to the proximal part of the small intestine, like the jejunum and the ileum, you might see a little bit more members creep up too that can survive. But once we get to the colon is that optimal place for that bacteria to grow and function as a community. And it has the greatest density and diversity in the colon, up to 10 to the 12th colony forming units. So billions of bacteria here. And we know that our microbiome is involved with a number of interactions. So it helps with nutrient metabolism. It's also involved with gastrointestinal function, our immune function, and even neuroendocrine responses to like the gut-brain axis. And a variety of factors actually influence our gut microbiome, not just diet alone. So it could be the drugs that we take or medications, the location of where we live. So my microbiome in Florida might look a little bit different than the microbiome in the Midwest or in the Northeast, or even out in Asia too. The life cycle also has been shown. As we get older and as we age, our microbes change with us too. The birthing process, whether you were breastfed or formula fed, that can also influence our microbiome, as well as external stressors too. So exercise, metabolic, or even psychological stress too. But obviously, because I'm the dietitian in the room, we're going to focus more on diet and the microbiome. But before I go into diet, I really kind of want to explain the gut barrier and why it's critically important for our health. So looking back at the colon, right, it looks like this big tube, essentially. And along this, in the colon, you have tons of different colonocytes and cells that are lined together to create a barrier. So the inside of the gut, called the gut lumen, is where you'll find the majority of those food particles in the colon, bacteria, as well as other signaling molecules to like short chain fatty acids. And how bacteria actually cross, or the intestinal barrier, is through the mucus layer first. We have this protective mucus layer here. And then within the colonocytes, we have a number of different immune cells that can activate during times of inflammation or activate during times of trying to reduce the number of inflammation going on. But essentially what's going on is you have different immune cells serving the lumen here, right? And if it sees any pathogenic or toxins, what happens is it activates this pro-inflammatory process. And during that process, you might see some opening between these tightly bound cells, and that can further promote inflammation, or what's also called leaky gut here too. And then hopefully you have enough nutrients and signaling molecules to signal these anti-inflammatory components like our T regulatory cells to really dampen down that inflammation. Because a little bit of inflammation is good. We need it to fight off certain bacteria, pathogenic bacteria, viruses, toxins. But when we have too much inflammation, what we start to see is a damage to this barrier. So you might see this mucus lining start to decrease, and those opening between cells too, promoting that leaky gut process. And when it comes to the microbiome in Parkinson's, I feel like we're still at the cusp of research right now. What previous studies have found are Lewy bodies, so those aggregated alpha-synuclein proteins that are found in the brain. Previous research has found Lewy bodies to be present along the GI tract in Parkinson's. So this has a lot of people thinking that the gut is really connected to the brain. But right now, we don't really have a good idea whether or not it's associated with developing Parkinson's disease or disease progression, but that it is one theory out there. And we do know that changes in gut bacteria have been documented in multiple studies in Parkinson's. So we see decreased beneficial bacteria and an increased abundance of pathogenic bacteria, which can further promote that inflammatory process, leaky gut, as well as constipation too. And I would say if you're more interested in learning about inflammation, Parkinson's, you should really check out Dr. Tanzi's lecture she did for this group as well. She did an excellent job there. And then this figure right here is just a demonstration to show how the gut and the brain are really connected here. So you can see here, if we have this immune system dysregulation and increased inflammation and that leaky gut, our neurons that are in our gut, our enteric nervous system, can signal through the vagus nerve and potentially further promote inflammation in the central nervous system. Now, this is just one proposed mechanism. I would caution to say that this is a fact that this happens. But to keep it a little bit lighter here, let's focus more on diet. So we know when it comes to diet in the microbiome, the foods that we eat shape the makeup and the function of our gut. And those bacteria utilize whatever energy source is there to break it down and grow more bacteria and stay present in the colon. So it'll use fiber, it'll even use proteins, etc. And we know that the bacterial gut microbiota are really important for, like I mentioned, vitamin production, so thiamine, folate, vitamin K, as well as the breakdown of dietary fibers into short-chain fatty acids. And we even know that they can cross-feed off each other. So what one bacteria utilizes and produce, and they make another, produce another substrate. Essentially, another bacteria can come in and utilize what that bacteria made and utilize that for an energy source here. So I have a better picture of that, how that kind of works here. So these are the variety of different substrates that bacteria can use to grow and use for energy in our colon. So we have dietary fibers, resistant starches, which can be utilized to produce short-chain fatty acids, such as acetate, propionate, butyrate. And I'll say, because I didn't mention it earlier, but how these short-chain fatty acids work, they work as different signaling molecules that can really affect our immune function, even appetite, mood too. And those bacteria can also utilize from cross-feeding those short-chain fatty acids to make more short-chain fatty acids. We also know that bacteria can use bile acids that are produced from the liver and conjugate them into secondary bile acids to be reabsorbed. And they can even utilize undigested proteins and amino acids to produce a little bit more not so great molecules like ammonia, sulfur, etc. too. Too much protein fermentation can be a bad thing. So that's why it's really important to make sure that we get enough fiber in our diet too. Let's focus first on short chain fatty acids, specifically butyrate. So butyrate, I love talking about butyrate. It's because I consider it the golden child of the short chain fatty acids. And that's because it's a major energy source for the health of our colonocytes, so those cells that line the intestinal tract. But even though it's a major energy source and it's considered that golden child, it's really the least abundant short chain fatty acid produced by intestinal microbes through fiber fermentation. And butyrate producing microbes frequently rely on the cross-feeding from others, like I mentioned. But why it gets a lot of the attention is because it has a very strong influence on how our immune system works, as well as transcribing certain anti-inflammatory genes too for our body to produce. And we know just based on previous studies, like you can see here, that when we don't get enough fiber in our diet, that can lead to the destruction of that intestinal barrier, which is really critical for our health too, and further promote inflammation here. So in this study, they transplanted stool into mice, and they fed those mice either a fiber-rich diet or a fiber-free diet. And what they found was that particularly that mucus layer and those colonocytes, when they had a high fiber diet, a fiber-rich diet, that mucus layer was nice, healthy, able to protect any of those bad bacteria or toxins out from entering our system. But when they had the fiber-free diet, you see that major destruction of that mucosal layer, as well as those colonocytes too. So fiber, pretty important. So let's talk about it. So there's many definitions of fiber that you'll see here. So, but the main one is that it consists of non-digestible carbohydrates and lignans that are intrinsic and intact in plants. However, in 2016, the FDA updated the definition of dietary fiber and added isolated or synthetic non-digestible soluble and insoluble carbohydrates that the FDA has determined to be beneficial to humans, essentially. So when it comes to intrinsic fibers, those are the ones found in vegetables, whole grains, fruits, cereals, bran and flaked cereals and flours. But those isolated or synthetic non-digestible fibers that are beneficial can be things like beta-glucans that come from oats, cellulose, pectin. A lot of people said that they were eating Honeycrisp apples today, which I also was myself. You'll get a lot of pectin there. Guar gum, psyllium husk, inulin, and GOS. And I will point out, inulin is definitely one of the more commonly added fibers that you'll see in food products. So our favorite Fiber One bars are highly packed with inulin in here too. So if you're having trouble getting enough fiber in your diet and you have a sweet tooth, something like this Fiber One bar can be a really beneficial way. I think it's about 6 grams of fiber in there. There's also insoluble versus soluble fibers. So you have insoluble, which don't hold any water in the stool, but it can help with bulking. So things like all bran cereals can be really helpful, especially when managing constipation too, because it creates more bulk to the stool. Soluble fibers increase water holding capacity, so it makes it more gel-like. So if you have hard stools, soluble fibers like oats can be really helpful for creating a gel like viscosity. But then you also have fermentable versus non-fermentable fibers too. So fermentable meaning that the bacteria can break those fibers down as an energy source, and non-fermentable meaning that they can't. And when it comes to dietary fiber in Parkinson's, we know that the recommended fiber intake for US adults is about 14 grams per 1,000 calories. So that would be about 28 grams for a 2,000 calorie diet. In the US, most people only consume 14 to 18 grams per day of fiber. And we know the lower fiber intake that we have, the increased risk for constipation that we will see. And most of the data, especially nutrition data in Parkinson's, is mainly from other countries, specifically like Italy, Asia, where the average fiber intake is up to about 30 grams per day. So this is something I just want to point out to keep in mind when interpreting some results of nutrition research too, especially when it comes to the microbiome or any type of constipation related research that you might see out there. But what about prebiotic fibers? That's definitely something that we hear quite a bit. So it's a substrate that's selectively utilized by a host microorganism to confer a health benefit. So not all fibers actually meet this definition. And ISAP, which is the International Scientific Association for Probiotics and Prebiotics, is a really great resource if you're interested in learning more about what constitutes a prebiotic fiber. Sorry, I'm going to move a little bit quickly because I want to make sure that we have enough time for questions. When it comes to probiotics, these are those live microorganisms, but they have to confer a health benefit to the host to be considered a probiotic. And we know that when it comes to the benefits of probiotics, they are species and strain specific. So evidence, so how they differ from fermented foods is that a fermented food does not require a health benefit to be demonstrated. So an example would be like a yogurt, kimchi, cheese, some breads. Those are all fermented foods that may or may not have bacteria in them, and they might not have any documented health benefits shown. There's also symbiotics, which are a combination of probiotics and prebiotics, as well as now the new term is postbiotics. So delivering bacterial products as a supplement. So you can find butyrate now in some cases as a postbiotic. And what's really great is that if you're interested in learning more about probiotics, remember how I said they are species and strain specific, but you're like, okay, I don't know which probiotic would be best for me. There is a website on the usprobioticguide.com, or this clinical guide for probiotics. It actually lists, it's a very comprehensive list of probiotics that are available in the US and what the strain is and what application, what documented benefit it's been shown. So you can see some in constipation here, a lot in antibiotic associated diarrhea too. Okay. With Parkinson's, only a couple studies have been done in terms of probiotics. The first one was done in 2016 where they used a symbiotic drink, and they found that people who drank this drink with a 7 or almost 8 grams of a prebiotic fiber and a number of different species here were shown to have more complete bowel movements in people with Parkinson's compared to those who drank the control drink. I've tried to look up finding this strain of a probiotic drink here in the US, and unfortunately can't find it here. So something to keep in mind. But a more recent study looked at specifically a probiotic combination and showed that this probiotic supplement that they did increased spontaneous bowel movements after 4 weeks. However, the average fiber intake at baseline was about 30 grams per day. So remember digging into the research, looking at what was their fiber intake like. And they found that it did not improve stool consistency or constipation related quality of life. And that's probably because they already had a pretty high fiber diet to begin with. So adding in more probiotics probably wasn't going to do much of a benefit anyways. But the bottom line on fiber, prebiotics, probiotics, and the microbiome is that diversity and richness of the bacterial species is what matters in terms of health and when building a healthy gut microbiome. So we know that incorporating a variety of plant foods is associated with greater species diversity. So, focusing on, we know that most Americans don't get enough fiber in their diet. So really focusing first on fiber is what I recommend to people. So bringing that fiber intake up closer to that 25, 30 grams per day, getting in a variety of plant foods too. So I tell people, eat the rainbow. We know that different fruits and vegetables provide different sources of fibers, which will help promote different species of bacteria to grow in our gut and confer hopefully a health benefit to us. And once you've established that baseline and you're doing a great job there, that's when prebiotics, probiotics might be sometimes helpful for managing GI symptoms. But more research is really needed in terms of managing probiotics in Parkinson's disease, specifically not just GI symptoms, but also motor symptoms too. All right. I didn't get to actually go through the rest of my slides that I have today, but I'm going to really end it here. So that way I can get to your questions too. Maybe you might have a question on some slides that I already have prepared. But yeah, main takeaways is increase your fiber intake, eat a diverse diet in plant foods, eat that rainbow, and then start looking into prebiotic and probiotic supplements for that microbiome too. Perfect. Yeah. And with that, I'll take whatever questions everyone has.
Perfect. And actually, your closing leads right into the first question, and it has to do with fiber and FODMAP. So, if fiber is good, but I experience bloating and gastroparesis, so psyllium is bad and I should avoid FODMAP foods, what's left to eat?
That's a great question. So I would say still plenty. So the purpose of a low FODMAP diet is to first eliminate all of those fermentable fibers too that could cause those gas and bloating symptoms. From there, once you've done the elimination, that's when you actually start adding back in fibers into the diet. Okay. So for example, I'll take avocados, a nice example. Avocados. So if you eat a whole avocado, the amount of fermentable fibers that you are delivering to your gut is very different than a quarter of an avocado, right? So once you've completed the elimination diet, so typically about 2 weeks or so, that's when you start slowly adding in small amounts of fermentable fiber. So whether you're saying, okay, today I'm going to try a quarter of an avocado to eat. Try it, see how you feel. You might feel great. You might not notice any difference. So now you know a quarter of an avocado is fine. Maybe you can increase it up to a half. And that's kind of your stopping limit. The Monash University, they have an app that is really helpful for showing you what's a high FODMAP food and a low FODMAP food. And they actually will break it down into serving sizes too. So that way you can still choose a bunch of low FODMAP foods, whether it's like, for example, like lettuce, kale, spinach, etc. And then that way you can start increasing maybe some of the medium FODMAP foods too.
That is very helpful. And I think that you said that during your slides, bring in a professional, work with, yes, maybe there's a million Google results when you search low FODMAP, but it's complex, especially with, if you have a a complex medication regimen. So
Yeah, and it might mean going on a very low fiber diet for a short period of time, but then reintroducing more fiber back in later once you've gotten a better manage of your GI symptoms.
okay. We also had a question about H. pylori
Mhm.
and Sibo. Are those the same thing? I've had H. pylori multiple times and then I'm given antibiotics, but I'm wondering if it's a symptom of a greater issue.
Yeah, so that's a great question. I'm not exactly sure the right answer. I would say they're probably connected. We know that H. pylori infection is very common, particularly in people with Parkinson's too. It's definitely possible that it's connected to SIBO. And so I would encourage you to, if you've had recurrent H. pylori infections and you're still experiencing symptoms, definitely would encourage you to go back to the gastroenterologist and talk to them about evaluating you for SIBO.
Okay, and there's been a couple questions about timing meals with medications. Um, and I know that's always a question. I don't know if that's more of a neurologist question or if you feel comfortable answering that.
Mm-hmm. Yeah, I mean, so part of being a dietitian is I can talk about food drug interactions too. So, timing meals with medication. So, I'm assuming this person's probably talking about Cinemet, so that carbidopa levodopa. I've talked about this on our previous uh, lecture that we webinar series that we did, but essentially, um, Cinemet or that levodopa within Cinemet can potentially interact with protein. So often it's recommended to consume on an empty stomach. Usually 30 minutes before meals or an hour or so after, usually 2 hours after a meal. However, Cinemet interactions with food really affect people so differently. I have some people that have to take their Cinemet with food, or else they'll get very nauseous and they don't notice any difference if they take it with food in terms of their motor symptoms. And then I have other people who look at food and they feel like their symptoms are worse. So I would definitely work with your neurologist. If you have access to a dietitian, they would be really helpful to figure out your individualized symptoms that you're experiencing and how you should time your medication with your meals. If you don't notice a difference, I wouldn't be worried about medication timing right now. You might experience that later, but if you're not noticing it right now, I wouldn't stress too much about it.
Very good, thank you. There was a question if you have loose stools or bloating or gas problems, should you still take fiber?
Yeah, that's a good question. That's definitely going to be the type of fiber that's really important to distinguish. So, insoluble fibers can be okay. So, the ones that cause a little bit more gelling, they have a little bit better water holding capacity. Most of the time, bulk producing fibers, so insoluble ones like, for example, cellulose is an insoluble fiber found in a lot of leafy greens. That actually how it functions too. It irritates the lining of that gastrointestinal tract to draw more water in. So if you have loose stools, you don't really want to eat too much insoluble fibers either because you're going to irritate the lining. So you can still have soluble fibers like oats, even certain pectins too that come from fruits like apples and bananas. Those should still be okay, but not. It depends on the type of fiber. If you don't have stomach emptying issues, psyllium can actually be a great way to bring in more water into or hold more water with the fiber to manage diarrhea.
And someone did put in the chat that psyllium works for them. So I think that you just addressed maybe
Excellent.
why Parkinson's so diverse. So
Mhm.
we're all unique and should. And another reason to work with a registered dietitian and have an expert on your team. Um, Someone asked about hydration multipliers and the role of hydration and water in all of the things that you've talked about.
Yeah, so I think I'm a little confused with, I might not be as familiar with the term hydration multipliers, but essentially how hydration works in terms of managing GI symptoms, specifically constipation, is very simple. It keeps more water in the colon to make those stools a little bit softer and easier to pass. Water is mostly reabsorbed in our colon. So when we're dehydrated, we're not getting enough water in our bodies. Our body wants to use that water in the colon to provide fluid and hydration to the rest of our cells and organs, right? It's not really super concerned with our stools that are hanging out there. So adequate hydration can really make sure that there's enough water and hydration in those stools to make them softer.
Okay, and I think hydration multipliers, it's a product called Liquid IV, and it has some cell technology, newfangled something. So,
Got it. Yeah, so how some of those work is more on the dehydration end rather than the gut per se. So if you are at risk of becoming dehydrated, so having low sodium, losing a lot of electrolytes, sometimes rehydration supplements like Liquid IV, Gatorade, Powerade, those can function to facilitate more sodium to cross the cells, and as well as other electrolytes like potassium too.
okay. And this is probably a hard question, but what's the best diet to stop weight loss? Any tips?
To not lose any more weight, correct?
Correct. The opposite of what, the
Yes.
entire world is asking, really.
Yes. Great question. So I'll keep it simple. High calorie and kind of high protein, depending on how sensitive you are to cinema and protein. And the reason that is when it comes to weight loss, that means that the energy that you're expending, so calories, the calories that you're burning, are now excessive of the calories that you're consuming. That's the fundamental law of weight management. So if you're burning more calories than you're consuming, the only way to stop weight loss is to get more calories in. Now, that's when there's kind of a hierarchy of needs, right? If we're becoming more malnourished, frail, and we're experiencing other symptoms where maybe eating, a bunch of fruits and vegetables isn't realistic right now, that's okay. Let's get in some of these high energy foods. Bene Calorie is a great supplement. You can find it on Amazon that can give you 330 calories in 1.5 ounces. I use that commonly. If you want a more natural, healthier option, avocados are also a great way to add more calories. Olive oil, adding sauces to foods, even nuts too, and nut butters.
All right. Well, the time flew by, and I echo a lot of people put in the chat that your illustrations were great, your slides were great. It was such a perfect blend of science and practical tips. We all learned a lot, right? Raise your hand if you learned something. I think I've heard a lot of talks about Parkinson's and nutrition, and this was excellent, Carley. So thank
Thank
you so
you.
much for joining us.
Thank you so much. Yeah, and I mean, before you guys go to really quick, I just wanted to share, I know some people have signed up, it's okay. If you live in Florida and you're interested in, let me switch this. If you live in Florida and you're interested in doing more nutrition research and you have Parkinson's, we're doing a Mediterranean diet and constipation study. And I know that Kelly will make sure that you guys have my slides too, so you might be able to see some of those slides that I didn't get to show. But feel free to go to tinyurl.com/MPD study, or you can call 352-340-7321. and would love to get you participating in more research.
We have a lot of Floridians, so I bet many will be interested in joining that research. And the Mediterranean diet, that just sounds delicious. So thank you. Thank you, everyone, for your attention. And again, we recorded this. The slides are available. That was a dense 60 minutes with a ton of information. So it will be available for you to refer back to. And again, let's just show our gratitude to Carley for joining and invite you to turn your camera on and give a goodbye wave of gratitude. So thank you so much for teaching us today, Carley. Really appreciate it.
You're all so sweet. Thank you for having me again.